What is the definition of premature ejaculation? Some guys might think 1 minute, some guys might think 5 or 10 minutes is too soon.
It's in the eyes of the beholder from the patient's point of view, but in our field point of view, to publish, to diagnose, it has to be a minute or less.
What are the different challenges that the different sexes have when it comes to sexual dysfunction or problems?
They have the same challenges emotionally because whatever your partner is, whatever preference you have, you're still sharing it with other individual or individuals, depending on your preferences.
Dr. Goldstein is considered the founder of the field of sexual medicine. Hello and welcome to the Enjoy Life Healthier podcast. I'm Jason Kam. Thank you so much for joining me today. We have an absolutely fascinating guest and a fascinating topic. I think you'll agree when we dive into it. We've got Dr. Irwin Goldstein with us. Dr. Goldstein is considered the founder of the field of sexual medicine. He's the director of San Diego Sexual Medicine, where he maintains his clinical practice, and is director of sexual medicine at Alvarado Hospital. He's been doing this for a very long time. He's studied it. He's written books. He's treated, I don't know how many thousands of patients. He is a real expert on sexual medicine, sexual disorders in both men and women. And we're going to be taking a deep dive into Dr. Goldstein's career, what the latest is, and we're going to answer a lot of important questions here today. So why don't we jump right in, Doctor? Why don't you tell me about your background and how you got into the field of sexual medicine?
Jason, first of all, I greatly appreciate this opportunity. Thank you for this podcast. Listen, you guys play a huge role. I mean, we're the practitioners, but we don't spread the word. So we're like in a little corner of the planet. You guys disseminate, and that's I think way more important, to be quite honest. So thank you for doing this, and thank you for talking about sexual issues. These are embarrassing, humiliating, and very private concerns, and over the years, nothing has changed. The embarrassment, humiliation is still prominent. I had just in the office yesterday a 19-year-old who flew from England. He had taken a hair growth medicine called finasteride that helped him achieve better hair, but by virtue of the role of finasteride in depleting certain hormones in men, he developed a very predictable sexual dysfunction, and he's never told his family. He got on an airplane, flew to San Diego, it's about 10,000 miles, and crying the entire time, his whole life as a 19-year-old who's changed. So the concern about sexual issues never changes. It's a universal concept. So I'm an individual from Montreal, Quebec, Canada. I played hockey my entire life, starting probably at age 2 or 3. I played captain of my high school team. I played college hockey at Brown University for 4 years. I played hockey at McGill University. So I'm just I'm an electrical biomedical engineer, hockey player. And through serendipity, I ended up in medicine, and through even more serendipity in sexual medicine. But my focus as a physician over 4 decades has never changed. I need to understand why people have certain medical conditions. I don't come to it as a physician where here are my tools, let's fix you, and 10 minutes later move on to the next patient. Each patient to me is this unique puzzle, and we spend 3 hours with each patient, so that's our model. We have a biopsychosocial situation with the therapist, myself, physical therapist, nurse practitioner, and we sort of have a cadre of diagnostic equipment to get to the root of the cause of the sexual problem. It's usually very complicated. Multiple triggers are playing a role, and it's kind of a detective's game. But it's been an amazing journey, and I'm very happy to share all this with you and with your listeners. And I think my prime goal today is to get people comfortable with seeking help, because the first issue is just admitting you have a problem, because coming out is kind of a difficult thing.
Yeah, and it sounds like you're seeing patients, obviously both genders, 19-year-olds, older people, everything in between. But why don't we start by discussing the connection between sexual health and our overall well-being? Why is it important to address sexual health in the context of, our general health?
That's such a fascinating question, and I wish I knew more about it. I'm a urologist, so I come to it without that psychological connection. We have a psychologist. I've been with the same psychologist for approaching 20 years. We sort of grew up in the field together. Listen, you could be the most successful CEO. You could be the most successful psychologist. You could be presenting at international audiences. And if it's another story. Yesterday, I saw an attorney in a great practice in a midwestern city, Albuquerque, and he has ED, and he's devastated. And you look at what he's achieved and accomplished in his professional life, but at the end of the day, you have to perform with your intimate partner, and failure to do so is quite important. I think it's a kind of a central issue, that's not discussed, and I think that's what makes it so important.
So you're a founding editor of the Journal of Sexual Medicine. How have you seen research in sexual medicine evolve since its inception? How have things changed over the last 30 or 40 years since you've been practicing?
Fabulous question. I'm actually an editor for 22 consecutive years, and in the year 2025, for the first time in 22 years, I will not be an editor, which is kind of an interesting declaration. What am I gonna do with my time is do more research. So, initially, the field, those who were involved in the field in the 70s and 80s and 90s, where we didn't have societies, we didn't have journals specifically dedicated to sexual medicine, published wherever they could, but it was kind of complicated because there were not many reviewers who were familiar with the field. So we needed to have specialized journals who had specialized reviewers who understood the field. So that's where the journal gets involved. The initial research is mostly descriptive. It's case reports. I saw Mr. Smith who had hair loss, and he took this drug, and he's presenting to me. And then case series. So I saw 10 people whose men were taking this hair loss drug, and they have a thing. And now we're doing clinical trials where we study individuals with the condition of ED. We provide a therapy for them. We do it in a sham or placebo-controlled manner. We compare control groups to actively treated groups. I mean, it's becoming way more like other fields of medicine. It took a long time, and we're nowhere near the degree of those high quality papers that other fields have, but we're clearly going in that direction.
So you've been involved in, research for both men and women's sexual health. What would you say the unique challenges are in diagnosing and treating sexual dysfunction in either gender? You could start with either men or women. Really, what I'm getting at is what are the different challenges that the different sexes have when it comes to sexual dysfunction or problems?
Again, another fabulous question. I love working with you, Jason. Listen, they're the same. It's so ironic that they're the same. They have the same challenges emotionally because whatever your partner is, whatever preference you have, you're still sharing it with other individual or individuals, depending on your preferences. And it's in a sense a performance. A woman needs to arouse and engorge and lubricate and climb and build the mountain, get to the other side, have pleasure, satiation, in the same context, pleasing the partner. It's a mutual kind of experience. The man has to perform. If penetration is the goal, the item that is being penetrated has to be firm enough to penetrate whatever orifice it's going into. I mean, the fact of the matter is there's more shared issues than there are unique individual issues, I must say.
So if we start with the guys, what would you say the major causes of erectile dysfunction are? I'm assuming ED is the primary issue for men's sexual health.
Well, it's interesting, at a practical level, a provider seeing a man who had a sexual problem, that is clearly the number one thing. Truthfully, though, in epidemiologic studies, a more common medical condition, is actually premature ejaculation. It's interesting that we don't have therapeutic options, to the same degree that we have for ED, so premature ejaculation, because it's not much to offer in several contexts, although we have really grown and developed and really now treat premature ejaculation much better. I don't wanna write that off. I'm just saying we're a specialty unit, so we have a lot of treatment options for almost everything. But in general, the general community doesn't have much to offer for early ejaculation. Again, another fabulous serendipitous, story, which, really changed my career in the premature ejaculation world. So we have, disease-modifying strategies for men with ED to address the underlying pathology. So if there's a psychological issue, we give psychological care. If it's a hormonal issue, we have hormonal care. If it's a neurologic issue, I mean, we'll operate on people's spines who have herniated discs if we can prove that that's the reason for their ED. So what's called disease modifying. The most common cause of ED is a vascular issue like high cholesterol, diabetes, hypertension, obesity, aging affects hearts, it affects the penis the same way. And the major tissue element of the penis is its muscle. The muscle is the thing that drives it, like your heart. If you don't have good muscle function, you can't squeeze blood all over with each second that the heart beats. So if you don't have the good muscle in the penis, it's not going to achieve the same hard pressures and sustained pressures in the penis. You'll have heart failure, you have, I guess, erection failure in the same context. So there's a strategy that increases muscle to the heart. It's called shockwave of the beating heart. It's a published item. And there's shockwave to the penis. And shockwave, both of these strategies are regenerative and can increase muscle. We have a lot of data to show this. So we're doing shockwave on this patient, and we typically apply it to all places of the penis. We typically apply it with a certain energy. It's millijoules per square millimeter. And I apply it to this patient, and I'm putting it right on his penis, and he screams bloody murder. He says, "Oh my God, that hurts." I said, "Oh my God, I've done this on hundreds and hundreds of people. We're not getting that response." I said, "Your penis is highly sensitive in this area." So the area I put it on was his frenulum. I don't know what you know about a frenulum. There's this little strip of tissue in the front part of the penis that's really sensitive, and it's involved in promoting sensation during sexual activity and orgasm. But this guy's frenular area was bizarrely sensitive, and he screamed. And I just said to him, curiously, I said, "Do you have premature ejaculation?" And he says to me, "Oh my God, Dr. Goldstein, that's my darkest secret. I'm so embarrassed about that. I can't last more than 30 seconds. I haven't told anybody. I tell all my partners, don't worry, I'll have a second erection and I'll have a third erection. I'll take care of you. But I've never told anyone." And then we have this concept that we've never had before, which is a diagnostic tool for PE. No one's ever developed anything that can diagnose PE. So, anyways, going forward, when people come in with PE, I take this shockwave machine, I put it in their penis, they yell and scream, and we're now developing this construct that premature ejaculation is a focal in a region, penile, what's called dysesthesia. That means an abnormal sensation. Esthesia is to feel dysfunctional feeling. So focal penile dysesthesia, where we can now focus So we ask people, do you think there's a certain region of your penis that's hypersensitive? Holy God, when I touch this thing, I ejaculate in 30 seconds. So we now have strategies that focus on that. I'm not going to get into any more detail, but it's the way this field works. And I said at the beginning, if you have 10 minutes and you go see a patient in under 10 minutes, but if you have 3 hours with the patient, you can actually unravel some of these mysteries, which is
Well,
what we're trying to do.
Well, this is great information because this is, I'm sure premature ejaculation is something that a lot of people don't like to talk about. They may not even tell their doctor. But what is the definition of premature ejaculation? How, you know, some guys might think 1 minute, some guys might think 5 or 10 minutes is too soon.
Well,
What is the
obviously,
clinical?
yeah. So it's in the eyes of the beholder from the patient's point of view, but in our field point of view, to publish, to diagnose, it has to be a minute or less.
A minute or less.
Yeah, a
And
truly uncontrolled situation. There are a few more requirements to the definition, like it has to bother you. Some people doesn't bother you, you don't really have the situation, and it has to be repetitive. In other words, can't just be one time this happens. It has to be that this is the way you have done it. Typically, it's all your life, but it can be acquired over time.
And this new treatment option, is this something that's like brand new? Like, what should our listeners know about this as a potential thing for them to explore?
Yeah, I
Even
haven't gotten
maybe,
to publish it yet. It's quite
oh,
brand new.
okay. So
Although
it's still
we've been
early.
treating it for several years with great success, may I say. But there's just so many things going on. I haven't gotten to get to that element. But yeah, it's very cool. Focal penile dysesthesia is a new, at least from our perspective, it's a new basis for PE that is very treatable.
Interesting. Wow. I have a feeling a lot of our listeners are going to reach out to you
It would be
with,
my honor to help them.
yeah. And you're in San Diego. Just
I am in glorious, beautiful, the finest city in the U.S.
it is beautiful. And I'm sure people from all over the world come to see you about these issues.
We see people from all over the world, yes.
Interesting. So let's talk a little bit more about ED. We'll turn our attention to women's sexual issues after we, cover the guys. I would imagine in your long career, one of the biggest sea changes must have been sildenafil hitting the market in I guess it was the mid to late 90s. How has Viagra and its, offshoot drugs changed how you treat sexual dysfunction in men?
Everything. Single word
Not
answer.
surprised.
This is the thing. So, you don't know this, and you don't need to know this, but I'll tell you. In 1991, we have a big science research lab, and we were the first people in peer-reviewed literature report actually what the chemical was that was released during penile erection. I have to tell you, that was a huge, huge dilemma. People were getting erections since day one, going back to Adam and Eve and beyond. And the actual chemical nature of what was happening to cause erection was only first described in 1991. That came from our lab. We were very involved with Pfizer in the development of Viagra. I mean, I was in Sandwich, England, the location that they did this multiple times, and I worked with Pfizer people developing the trials, going to the FDA with them, et cetera, et cetera. I was the first author, May 14th, 1998, New England Journal of Medicine, that released all the data to the general medical community. And the consequence of being the first author was you were the corresponding author, and therefore I received the phone calls, 10 million, and the letters, 10 million, from individuals wanting more information. And through serendipity, let me ask you this question. I'll interview you, okay? You're pretending to be me now. You're sitting in my office getting all these calls. We kept record of the gender of the person calling us to find more information on Viagra. What do you think that was?
Well, I would have said it was 99% men, but a lot of partners, I bet a lot of wives and female partners called. So I would say 60-40
Who's 60?
men.
80-20 women.
Wow. Wow.
And it wasn't about their partner. They said, okay, men have their Viagra. I have no interest in sex. I can't get an orgasm. It hurts when I have sex. I can't arouse. am I supposed to be doing this? It was how the field of women's sexual health started by the release of Viagra, making sexual conversation more accessible. It is a totally fascinating history. In that year, in 1998, we started the International Society for the Study of Women's Sexual Health. We said, okay, we don't know much about this. GYNs are not really investigating or putting effort into this. It's kind of like a no discussion zone in the GYN office. And we said, well, we need to put this together. We need to catch up to the knowledge we had in men. So we put together a society. It's now 25 years. It was 1998. We're getting to 2004. It's really grown and helped the field. Getting back to your question, though, ED um, was thought to be an elderly man's disease, a 70-year-old, 80-year-old, 60-year-old. And what has happened is ED has now become commonplace in teens and become commonplace in college kids and 30-year-olds. And unraveling the reason for that has been completely fascinating. There are another story of someone in the office earlier this week who at age 7, because of anxieties of going into kindergarten and first grade, was put on an SSRI antidepressant medication. And they have awful side effects sexually. And everybody, and even today, there's this sort of inaccurate concept that okay, you take the medicine, it's anti-sexual. It raises the inhibitor of sex called serotonin. So, okay, we have a mechanism why. But once you stop, everything goes back to normal. That's not necessarily true. There's this condition called post SSRI sexual dysfunction. The acronym is PSSD. And we're seeing people, even when they stop, continue on with the sexual dysfunctions that they have. That's just awful. And here's a guy who was given a drug, not with his permission. He was 7 years old. He made no decision. And now he's 19, 20 in college without any ability to have sexual activity. As we unravel the syndromes, we have people who are BMX riders. Okay? Here's their crotch, here's the saddle. They're going up and down, whacking away. The penis is right on in the saddle area. They're damaging their penis with every BMX ride. Professional riders, the Tour de France guys, all these avid cyclists, policemen who are doing bicycle community riding are all showing up with erectile dysfunction. People who take these hair loss drugs, finasteride, minoxidil, they're all developing erectile dysfunction, and on and on. We understood it was an elderly man's problem, but we never realized that there's a cadre of all generations having these issues, and it takes a detective to figure it out.
Are you seeing an impact with pornography and men's sexual dysfunction?
The literature for that is so blessedly confusing. It offers people a chance to get aroused and to learn about the anatomy. Um, Tell me where it's taught at any level in high school or college. You learn sex where you can learn it, but it's not taught in a scientific way, and it's yeah, there's people who abuse alcohol, and there's people who enjoy a drink at a celebration of someone's life. So it's like everything. There's bads and goods to all things, and I'm not anti and I'm not pro. I'm just saying here's the realistic thing. Computers have access to porn, and people are going to use it. And how can we help people who have problems?
So when you choose a medicine for a man, you
Yes.
have different options now: Viagra, Cialis. I think there are some newer ones, maybe. How do you choose which medicine, or are they just interchangeable?
Yeah, when you work for a company, they say how fabulous their drug is compared to all the drugs. The truth is they're pretty much all the same.
Mm.
And the truth is, before they ever get to me, they have tried and failed Viagra. I mean, Viagra is no longer exclusively used by ED people. I mean, it's used by people. The college age people, if you're going to say that's rare on campuses to have Viagra in the thing, it's used by so many people. It's just part of the landscape, and you have to deal with it. The people we see in general have already tried and haven't achieved their goal. Some people, their goal is to be more spontaneous without the need for it, and some people say, "I don't mind using it, but it doesn't work anymore."
Yeah, do you get habituated? In other words, if you start taking Viagra when you're a younger man, like in college, like you just said, and you use it regularly, or is it still going to work for you when you're in your 30s or 40s or older?
Well, there's no scientific evidence of toleration, so that's the science. But then you get into the mind. And the mind is a complex area. So, if you depend on it, and then you depend on it. It's just part of what you do. Some people find a glass of wine relaxes them before engaging in a relationship. So, are they addicted to wine, or you have your style and you do your thing. I love the conversation I have with patients who say, I take Viagra, but Dr. Goldstein, I don't need it. I said,
Right.
well, if you take it, it's because you need it. Let's be honest here, okay?
So, what do you do with patients who come to you and say, I ordered Viagra online, I've tried it, it doesn't work, or it's not delivering the results I want? What comes after these drugs when they don't or stop working?
Another great question. You're loaded with great questions, Jason. Here's the weirdest part of sexual medicine. If Let's pretend you go to the emergency room and you have chest pain, and you're a little anxious because you read somewhere that chest pain could be the hallmark of a heart attack, okay? And you go to the emergency room, and the guy says, "Oh, Mr. Jones, you have chest pain. Ah, here's what I do. Here's some ibuprofen and some aspirin, and listen, if it doesn't go away, come back and see us in a few days." Okay, what do they do at an ER? They do an EKG, they do a chest X-ray, they listen to your heart and lungs with a stethoscope, they get blood tests. Okay, you walk into a doctor's office with erectile dysfunction. Where is the construct? Okay, let's find out what's causing your erectile dysfunction. Why is it that we say, "Here's your erectile dysfunction, here's Viagra, and if it doesn't work, come back and see me"? In other words, where's the usual medical strategy, which says you have a problem, let's do a history and physical and tests and diagnose you what's wrong, and then we get a diagnosis and let's find appropriate treatments for you. That construct doesn't exist for sexual growth. And you ask me the question, the answer always will be, we need to do diagnostic tests. We need to find out the trigger, or in most cases, the triggers, both emotionally and biologically, hormonal, anatomic, vascular, neurologic. There's so many things that are involved in this process.
So, aside from SSRIs, are there other pharmaceuticals that can cause ED in men?
Oh yeah, there's gazillions. So all the cardiovascular things that lower blood pressure will lower blood flow delivery to the penis. And if you have high blood, yeah, beta blockers, alpha blockers, calcium channel blockers, ACE inhibitors. I mean, all of the hypertensives cause ED. The Epileptic drugs, prevent information from getting to the brain so you don't have a seizure, but they prevent sexual information from getting to the thing. This concept of finasteride needs to be described because it's a silent killer. Finasteride is a drug that you take that stops a specific hormone from being synthesized in a male body. It's called dihydrotestosterone. And let's argue dihydrotestosterone is not that great for hair if it's elevated, but dihydrotestosterone is really important for the penis. So a voluntary decision to stop the synthesis of a very specific hormone in your body, i.e., by taking finasteride, will injure the penis. and in certain people. And like everything else, it's not everybody, but it is definitely present in certain people. There's a condition called post-finasteride syndrome, PFS, which is a disaster. And it affects kids, because when you're 18 and 19, you see your father balding and you don't want to be your father. And you don't even have to go to a doctor. There are providers online. I'm not going to mention their name to promote them because I don't think they're very helpful to people. The informed consent you get on this is kind of bizarrely missing, and they take these medicines without knowledge. This kid, 19 years old, who flew 10,000 miles, is one of those guys.
Yeah, that's a disaster. My grandfather, I remember, once said to me, when a guy gets older, God could take one of two things away. Let it be the hair, he used to say. But yeah, I know there are people that can get finasteride online at any age, and I think most of them have no idea of the potential sexual side effects.
Yeah,
That if
it's
they knew, they
awful.
would never take it.
Yeah. Well, because those online groups are financially motivated, not patient
Yeah.
care motivated.
So what about women? I would imagine a significant portion of your practice, like kind of hinted at earlier, are women. And what are the biggest sexual health issues that women confront, or at least that you see in your practice?
By the way, Jason, I love this conversation.
Hmm.
I could spend 4 hours with you on this topic.
Thank you.
It's the most fascinating part of what I do. I'm the most passionate person on earth in trying to unravel. Um, um, there's just a different thing in the room when there's a woman discussing the issue versus a guy. A guy, it's very much performance focused, and it's way less that in a woman. I mean, the the dysfunctions include interest, libido, arousal, orgasm, and then the other issue is pain. And
Wow.
you can have a desire problem, and then when someone massages you and kisses you and provides you chocolates and care and interest, you can have responsive desire. You can eventually arouse or even not arouse. You can have your orgasm or not have your orgasm and fake your orgasm. But I have to tell you, when you're having penetrative sexual activity and it hurts, and every thrust is hurting and it's aversive, and you are trying to hide it so that you don't upset your partner, it's awful. And women who have pain are it's such a tragedy. And the knowledge of the reasons for pain, the knowledge for how to manage and diagnose these things is just minimal. And the medical gaslighting to women who have these pain conditions is sadly way too prevalent. And it's clearly one of my passions is try to unravel and help and treat women so they I get an email. "Oh my god, I'm having sexual activity and it doesn't hurt. Thank you so much for your care." I mean, that's
And
our payback.
what's the age range with women? Is it all over the place, like with the guys?
Yeah, so, women have their period sort of in 5th or 6th or 7th grade. They're 13-ish years of age. They wanna go to a swim park or water park, or they wanna go swimming with everybody else, so they place a tampon. A large percentage of women can't get a tampon in at age 13. Their very, very first penetration is very often a tampon. Failure to insert comfortably a tampon is not a good sign going forward. And there are many people who have that history. And then there are people for whom penetration is fine, and then they take a birth control pill. There's only 40 million women on birth control pills. That was a sarcastic statement. 40
Huh.
million women are on birth control pills. Let me just say publicly, every birth control pill, 100% lowers testosterone. I'm gonna ask you, Jason, would you take a medication sitting here now knowingly takes your testosterone and officially lowers it to very low levels? Would you take that medication?
Well,
Say no.
as a man, certainly not. If anything, I want more
Then why
testosterone.
would a woman
Well, why do women need more testosterone?
Well, that's not the question. The question is they're taking a medication for birth control. Listen,
Hmm.
contraception sadly falls on the woman, and it's really important to have contraception opportunities. It's just that that specific kind of contraception choice 100% lowers testosterone. Now, like everything else, it doesn't affect negatively the sexual function in all users. And I'm not dismissing the role and importance of birth control pills. They are. But let me say there are other options for contraception that don't lower testosterone
Hmm.
and don't affect sexual activity like birth control pills do. So there's 40 million women and they're teenagers and they may be in your own house. I don't know what your household looks like now, but you may be having them. And they may be having depression because testosterone is affected by, or depression is affected by testosterone levels, bone health, energy, mood, and then orgasm. And then, of course, it affects the quality of the tissues in the vaginal area and it causes pain. It's one of the leading causes of pain in women. And it's not discussed, not taught, not explained. And yeah, so why you here, your role in disseminating information on a podcast is just huge. Because for many people, this may be the first time they're hearing about this.
So, what are some treatment options that you recommend for women who are dealing with? Well, I guess there are different issues that have different potential treatment options or
Yeah,
preventative.
100% correct. The correct
Okay.
diagnosis is how you do this. So, the condition called hormonally mediated or associated pain of the opening of the vagina, that term is called vestibulodynia. Odynia means pain.
Hmm.
You can have chin-odynia, forehead-odynia, cheek-odynia, and vestibulodynia. It's a region of the opening of the vagina called the vestibule. So hormonally associated vestibulodynia is treated way differently than vestibulodynia from lichen sclerosis or lichen planus or infections, candidiasis. I mean, there's neurologic conditions, pudendal neuropathy. There's millions of issues. The idea is to diagnose it. Getting back to hormonally mediated, which is rampant in colleges who are kids are don't want to get pregnant, so they take a birth control pill, typically provided by providers who don't provide any risk information with birth control pills, only benefit with birth control pills. And when they get sexual dysfunction, they don't understand, they don't know. But obviously, to change the form of contraception outside of the birth control pill. By the way, birth control pill patches and rings are also negative. LARC, L-A-R-C, long-acting reversible contraception. There's a plethora of contraceptive agents, long-acting reversible contraception. They don't affect sexuality. And frankly, they're much better in preventing a pregnancy than, in fact, the birth control pill. So, which you have to take every day at a certain time, and don't forget it, et cetera, et cetera. So, the treatment for women with hormonally mediated vestibulodynia obviously is to consider changing contraception, address the blood test values, which are low. There are strategies that will change the low testosterone value to a more replenished testosterone value, an amazing success rate. It's one of our easiest and fastest ways to stop pain.
And what about low libido as opposed to actual physical sort of, dysfunction? We could start with the men because we didn't touch on that. There's erectile dysfunction, but what about guys that are just not their libido isn't as strong. They're not as horny as they were when they were maybe younger, and that's disturbing them. What do you recommend there? Would you just put them on testosterone?
Well, so the actual clinical term is called HSDD, stands for hypoactive sexual desire disorder. That's the official term. Low libido, I guess, would be the lay term, and the medical term is HSDD. So there are drugs officially approved by the US government to treat HSDD. HSDD is a condition that has many causes, psychological causes, hormonal causes, neurologic causes, erectile dysfunction causes. But if it gets to the point where all of those have been ruled out and that's not the issue, and there's a primary HSDD issue, it's a chemical imbalance in the brain. The agent dopamine, oxytocin, adrenaline are your driving chemicals in the brain, and the chemicals opioid, endogenous opioids, or serotonin in particular, are prolactin, are inhibitors. So this balance, this seesaw of excitation being greater than inhibition, then of course you don't have HSDD. But when inhibition flips the seesaw to inhibition greater, there are drugs out there. So there's a drug called Vyleesi, Vyleesi, which is subcutaneous bremelanotide. It's in a sort of one of these EpiPen things. You would inject that an hour before. It's FDA approved for women, premenopausal women. We use it in postmenopausal women, and we use it in men off-label. But we obviously have to discuss that with the men. And there's a drug, ADDY, ADDYI, which is flibanserin, which lowers the serotonin. So one raises dopamine, the other lowers dopamine, and changes the seesaw balance. So they're really good drugs for HSDD. Again, approved for women, used in both genders, off-label, certainly in our clinic.
Okay. Well, Dr. Goldstein, I know you have to run, and we could go for hours. I definitely would love to have.
Do this again, Jason.
I want to have you back to talk about
Yeah.
testosterone in men. And
Menopause management. We got to do menopause management. Oh my God.
we could do multiple episodes here. There's so much to explore and unravel. If you are out there and you have any questions or concerns, reach out to Dr. Goldstein. He is the director of San Diego Sexual Medicine, and he sees patients from all over the world. He could really help you out. I hope you've enjoyed this podcast. Dr. Goldstein, this was fascinating. Like I said, this is just a fantastic subject. Most people are really going to enjoy this podcast. So thank you so much for joining me today.
Jason, thank you very much. Appreciate it.
Okay.